Hello.
Hi, Rosemary.
Hi, how are you?
How are you doing?
I'm okay.
Good. I can sign off, or what would you like me to do, actually? I should say that.
Good afternoon. My name is Rosemary Walch. I am a new staff neurologist at Michigan Institute for Neurological Disorders. I am a multiple sclerosis specialist, having just finished my fellowship at University of Cincinnati. I am from Michigan, so coming back to Metro Detroit was coming home. So I'm very excited to be here. So today I'll be talking on a topic of multiple sclerosis-like diseases. So I've named this topic, I have multiple sclerosis. Why is my neurologist talking about other diseases? And I want to talk about the other diseases that we're talking about now that could look like multiple sclerosis, but act clinically a little bit different and are actually treated differently. So it's a good thing if your neurologist is looking outside of just multiple sclerosis. So multiple sclerosis, as we know it, is a disease that's driven by inflammation leading to relapses and cell loss. And this is when neurons undergo neurodegeneration. Disability is primarily driven by multiple cumulative relapses and then cell loss. We have a couple known phenotypes of multiple sclerosis. Relapsing remitting multiple sclerosis, which is by far and away the most common type of multiple sclerosis. Then we have a secondary progressive form of multiple sclerosis and a primary progressive multiple sclerosis. The other conditions we'll be talking about today, neuromyelitis optica spectrum disorder, also known as Divek's disease, has been known about for a long time, but advances in clinical testing and diagnosis have come in the past 10 to 20 years. This is a disease that is driven almost exclusively by relapses, and patients may go many years without a relapse. And progressive type symptoms are very rare for NMOSD. And then there's yet another disorder that can look like multiple sclerosis, and this is myelin oligodendrocyte glycoprotein associated disorder. That's why we call it MOGAD, because that's otherwise pretty long. This is a disease that is driven by relapses as well. Many have a good recovery. And this disease is unique compared to multiple sclerosis and NMOSD in that it may be driven by a one-time event and be completely monophasic, especially in children's. But others have a relapsing phenotype. So we still have a lot to learn about MOGAD and the different phenotypes that exist. So why we're talking about all these different diseases is that not everything that is demyelinating is multiple sclerosis. So in this cartoon, you can see that there's a circle for typical multiple sclerosis, and then atypical multiple sclerosis also surrounds it, but there's a little bit of an overlap with the MOGAD-related diseases, which MOGAD can have optic neuritis, it can have myelitis, it can have encephalitis, Aedem, and then there's still an overlap with this neuromyelitis optica spectrum disease. And then you can either have aquaporin 4 positive NMOSD or aquaporin 4 negative NMOSD. So let's talk about the epidemiology of MS versus NMOSD versus MOGAD. So multiple sclerosis is by far and away more common. Gender distribution for multiple sclerosis is about 4 females to 1 male, but neuromyelitis optica is far more common in females at 9 to 1. Myelin oligodendrocyte glycoprotein associated disorders we think is about a 1-to-1 gender distribution. The average age of onset in multiple sclerosis is 29. For NMOSD is about 39. And in MOGAD, it's children predominantly more than adults. Prevalence, MS is by far and away more common, occurring in about 300 to 400 patients in 100,000 people, versus NMOSD, which is about 10 in 100,000. And we don't definitively know about MOGAD yet, but we preliminarily think it's about 3 in 100,000 people. For race distribution, MS can occur across all racial spectrums. NMOSD has an increased prevalence in African Americans, and MOGAD also appears to be more common in African Americans, although this is still yet to be completely determined. Coexisting autoimmune disorders can occur in multiple sclerosis, very common in NMOSD, and we're not sure yet in MOGAD. And then the predominant cells that are involved and attacked when there's an inflammatory process. In multiple sclerosis, this is the oligodendrocytes. These are the cells that make white matter for your brain and your spinal cord. In NMOSD, it's the astrocytes, which are the supportive cells in the brain and the spinal cord. And then for MOGAD, they actually attack the myelin sheaths that cover your brain and your spinal cord, those tracks that go from your brain all the way down through your spinal cord. So let's talk about different demyelinating clinical syndromes that many of you may have experienced. You have optic neuritis, myelitis, brainstem syndromes, and encephalitis. So in different diseases, these all look a little bit different. So the vision loss that comes with optic neuritis for multiple sclerosis is typical, what we call typical optic neuritis. It's typically central vision and can vary with the degree of loss, most commonly unilateral, and usually recovers at least somewhat, often fully. In NMOSD, the vision loss can be much more profound, and it may be bilateral and may not recover as well. In MOGAD, it can also be bilateral, and recovery is variable. It's better than NMOSD, but not often as good as MS. Sometimes that vision loss is not painful, where typical optic neuritis is painful, that pain retroorbitally behind your eye there when you move it. Limb weakness can occur in all three diseases, and in MS, it's a variable amount depending on the extent of the relapse. In NMOSD, it could be more significant relapse weakness because it ultimately may result in paralysis. And for MOGAD, it's very variable amounts of weakness. Sensory loss in MS can be variable. In NMOSD, it may be significant, and in MOGAD, variable. And then there's a unique brainstem condition of protracted hiccups, nausea, and vomiting. And this is very intense hiccups, nausea, and vomiting that occurs for longer than 24 hours. It's very protracted. And we really do not see this in multiple sclerosis, and it's very rare. For NMOSD, it's one of the defining characteristics, so we see it frequently. And in MOGAD, we are not seeing it. And then altered mental status, what us as neurologists call an encephalopathy. Very rare to occur in multiple sclerosis, but has happened. In NMOSD, we sometimes see it. And in MOGAD, it's more common, especially in children. So going back to optic neuritis, we talk about classical or typical optic neuritis, which is optic neuritis that we often see with multiple sclerosis. It's a reduction of vision in one eye, and it occurs over a day to several days at a time. Your color vision is reduced. Your central vision is typically reduced, and it's described as a graying circle of loss, and there's pain with eye movement. Atypical optic neuritis, which we see more with NMOSD and MOGAD, is a severe reduction of vision in one or both eyes, and the color vision may still be reduced. And this can involve more of the visual field. It can be the entire visual field, the upper part, or the lower part, but not typically that central that we see with multiple sclerosis. And this MRI picture over here of optic neuritis, you can see over here, so this eye here is the right, and here's the left, and this entire optic nerve post-chiasm, which is this crossover back here, is inflamed and irritated. And that is very common picture for atypical optic neuritis. Myelitis across these diseases looks different as well. Myelitis, by definition, is inflammation of the spinal cord. So in MS, we typically have short segment, 1 to 2 vertebral levels in the back, and I will show you on the MRIs what this looks like. And it tends to affect more of the sensory tracts and the more lateral side of the cord. NMOSD is typically longer segments, usually at least 3 vertebral levels or longer, and involves over 50% of the diameter of the spinal cord. And in MOGAD, we're still learning about the type of myelitis that happens, but so it can be short or longer segments. So over in this MRI picture here, A, B, C, and D are multiple sclerosis. So it's a short segment. So this is one vertebral body right here. So this here is one vertebral body. This happens to be C2 and C1, which are merged together. Very common how they're set up anatomically. So, but here, this is C2, where I'm drawing a line. C3 is the box. So this is what I'm talking about when I say one vertebral body. So this is a short segment. Down here in B, you can see it involves the lateral side of the cord. And when it picks up that gadolinium that you all get with your MRIs, it has this partial ring enhancing, and this partial enhancing pattern around here on D, all very common for multiple sclerosis. Over here in E, F, G, and H, this is what typical NMOSD related myelitis looks like. So it's much longer. It goes down a majority of that cervical spine, and you see it's much wider than this over here in A. And then when we look down here at F, all this portion of the cord is involved. So over that 50% that we just discussed. Multiple areas of enhancement are happening over here in G, up here near C2 and C3. And then down here through C5 through C7 area, we're picking up all that enhancement, and same thing in the central portion of the cord down here in H. And over here in MOGAD, in I, J, K, and L, you see a different type of hyperintensity, and this is all in the central, and this is very characteristic of MOGAD. So when we as your neurologists go through your MRIs, we look at characteristics of what your brain looks, of what your spinal cord looks like. Does this look like typical multiple sclerosis? Does it look like atypical multiple sclerosis? Are there things in the imaging that makes us think about things like NMOSD and MOGAD? And keeping that broad differential is important that you all get the best care possible. Area postremia syndrome is a unique area of the brain that's involved in NMOSD, and it's a lesion in the medulla. So it causes intractable hiccups, nausea, and vomiting, and this is very unique to NMOSD, not seen in MS and rarely seen in MOGAD. That's an MRI picture of how big those lesions can be and extending through multiple levels and surrounding areas of that area postremia. Acute disseminated encephalomyelitis, also known as Aedem, is inflammation of both the brain and the spinal cord simultaneously. It's predominantly seen in children, and it may cause confusion or other mental status changes, and it's associated mostly with MOGAD, so that positive MOG antibody. And typically, this event is what we call a monophasic event in children, so they have a one hit, and then they recover, and they move on with their life. So how do we make the diagnosis, and how do we make the correct diagnosis? For multiple sclerosis, we use the 2017 McDonald's criteria. There have been multiple iterations of this criteria, and we are constantly reevaluating this criteria to make the best diagnostic criteria possible. But this is based on the principle of dissemination in space, so lesions in characteristic locations in the brain and the spinal cord for multiple sclerosis. So you do have to have MRI lesions to have dissemination in space to meet the 2017 McDonald's criteria. And then you also have to have dissemination in time, lesions that occur over time. So MRI separated by 6 months at a time with new lesions fulfills that criteria. A lumbar puncture may also substitute for this criteria, as it's a sign of ongoing inflammatory processes. For NMOSD, we use the 2015 International NMOSD diagnosis criteria. So it requires one core clinical event, so some of the things that we've been talking about, that optic neuritis, myelitis, or area postremia syndrome, plus a positive serum aquaporin-4 IgG antibody. And this only has to be tested in the blood. It's not another LP. So serum aquaporin-4 antibodies, also known as AQP4, are very specific for this disease. So if your antibodies are positive and you've had one of these clinical events, you have the disease. If you have negative antibodies and your neurologist is still highly suspicious, then you actually have to have 2 events required to make the diagnosis. And MOGAD, we're still working on proposed criteria from 2018, but it's very similar to the NMOSD criteria. You must have a clinical event typical of MOGAD, so optic neuritis, myelitis, Aedem, and then that positive serum, again blood, anti-MOG IgG antibody. So all of these diseases have relapses, and most of the relapses are treated very similarly. We almost always begin with IV methylprednisone. Sometimes you'll see that abbreviated IVMP, typically 1,000 milligrams daily for 3 to 5 days. NMOSD is more likely to require both steroids and an additional treatment, typically with plasma exchange. So plasma exchange is the extraction of your plasma, cleaning the plasma from the antibodies that are attacking your brain and your spinal cord, and then putting the plasma back into patients. MOGAD is very steroid dependent. It often requires some amount of steroids, typically oral, over 3 to 6 months, or we have to give steroids again if there's a transient worsening of the same symptoms that they presented with. So getting the diagnosis right, even from the beginning, is important. We always start with steroids when we are expecting demyelinating disease. Almost always, at least, start with steroids. So why getting the diagnosis is even more important now is that we have so many different drugs approved for different diseases. So for multiple sclerosis, we now have 20 drugs approved. The first drug approved was an interferon beta back in 1993. And then our most recent drug approval, ponesimod, was in March of 2021. For NMOSD, we have 3 drugs all approved in the very recent years. We have eculizumab, also known as Sclerosis, which was approved in 2019. We have Uplizna, which was approved in June of 2020. And we have cetralizumab in spring, which is approved in August of 2020. For MOGAD, we have no drugs approved yet, but we have many therapies that we use off-label, taking what we've learned from multiple sclerosis and NMOSD and applying it to MOGAD. And there are several ongoing immunotherapy trials. So in conclusion, not everything with optic neuritis and myelitis is multiple sclerosis. So as you're working with your neurologist, he or she may test you for other diseases now that testing is available and newer drugs are available. And some of you have already been tested for these diseases when your neurologist tells you, oh, your MS mimickers testing is negative. Many neurologists already test for NMOSD, aquaporin 4 antibodies. And now that MOGAD has been available since 2017 for commercial testing, many are also testing for that. And also, I don't want you to be alarmed if your diagnosis changes, since we now understand much more about all of these diseases, how to clinically differentiate, and how to treat appropriately. So if you have any further questions, I encourage you to keep talking to your neurologist, raising concerns about something you may have in what I've said. But rest assured that many of you have probably been tested for some of these diseases already. Thank you.